right, thank you for staying with Daybreak. We're talking about the state of healthcare. We've tried to diagnose what the issues are now. We're trying to look for the solutions. And Dr. Nyikal had mentioned that it's an issue of the ethos of the nation and committed leadership right from the top. But this is what the CS had to say. And this is not the first time a CS is talking about this issue. Her predecessor, CS Kagwe, also said that there were cartels and he was going to break them. But this is what Nakumicha is now promising.
This institution must be clean. We are going to uproot all the roots, all the evil spirits that have been planted in this institution. Nitazingoa.
Dr. Nyikal, I see you laughing at this. Are you convinced? Then I see you also Gigondul.
I am not convinced. Let me tell you something.
Yeah.
She's probably related. When I became Director of Medical Services and, you know, I was really fighting hard and talking about corruption, so I went home and he listened to me and he told me, you know, one person cannot remove corruption.
Yeah.
Even if it's a minister, he can. Told me the only person who can clear corruption is the president. Because even if a minister didn't want to be corrupt, but he was not supported at the top, and all the other ministers don't support him, he's the one who will be removed. So if you are a DMS and you think you're the only one, you are going to do it if you don't get support from the top, even if you are a minister. So I don't know, because I've told you, this time, what I'm waiting for is what prompted Principal Secretary Mburu to ask for change of specification. That's where the matter lies. It cannot be within, it is unlikely to be within the ministry. Because if it was within the ministry, then the minister wouldn't be talking like she knows nothing. Yeah, so that is the issue. So
that decision to change the specifications, ideally, how would that come by?
I don't know. I'll tell you. Let me do a little history.
So you're saying it's a pesticide issue, right?
Yes.
So it's an insecticide issue on the nets. So by the time such a decision is reached at, is there a meeting of some sort? Is there a meeting of doctors who recommend that
technical people
doesn't work for us?
In procurement, there is technical, the specifications are actually given by the users. If you want to do nets, you get the doctors and who know about this, you get the specialists and the people who make the nets, you get pharmacy and poisons board, you get the people in industry to tell you what would you need. They're called long-lasting insecticide-treated nets. And so what the important thing, either it is impregnated, the insecticide is impregnated in the net itself, in the linen itself, or it is put at the top. That one will wash up quickly. And then which insecticide? That's something that cannot be decided by one person. It should have been decided long time ago, the size of the nets and so on. But the most important thing is that. So how could one person just sit in our office and decide that? And so, remember, when we had the problem during COVID, the CEO of KEMSA actually came to the committee and said, I was getting instructions from the ministry. He even mentioned I was getting instructions from the minister. And you said he was getting it by phone and SMSs. I think about a week later he changed it. But what happened first? So it's a whole system. And if she's going to clear it, I hope she gets support. But I'll tell you why support from the presidency is important. When I was Director of Medical Services, more than 3 times when there was a decision where, you know, as a DMS, I was thinking one way or a new thing was coming, we always get, whenever it got to the president, he would just ask director what is the issue and explain, and tutafanya hivyo vile director nasema. Support from the very top, and you must support the officers. The minister needs support from the president. The PS needs support from the minister. The Director General needs support from that top. If they are free, and then with these technical people, and then the procurement person, the finance person, the account, if all these people feel that they can do it, they will also have interest, but they're very sensitive to what their bosses are thinking.
Yeah.
So it's a system, and I'm happy that this time there's been very quick action from the top. If that is deep from the heart, it will permeate through the whole system, and we'll see results. And then the minister's words can, although she say Nitazingoa, she cannot ngoa alone.
Okay.
There has to be other systems above her, around her, that agree that it should be done.
Okay.
So you are asking about what we do. Let me tell you, the main component of health system, financing. Are we giving it enough money? That is why we are toying with just tax alone, or we include insurance and NHIF. Human resource. Do we train and manage them properly?
Yeah.
Supply, that is KEMSA. And let me tell you about NETS. When NETS brought this thing 2005, and with NETS were coming, and they were all interest around it, we decided at that level that we are not going to receive money. We are going to have nets provided by the donors directly. So we asked UNICEF, bring the net. We were tired of interest. When we wanted the drugs Coartem, we said, let WHO procure Coartem. So we were tired of the interests that are around it. So that supply must also be protected. KEMSA must be protected. Then infrastructure. Look at, when we now look at MES, are they technical people who decided? Because I remember when the minister then, I think it's Macharia, there are certain issues we said in the committee, don't sign this until 1, 2, 3 has happened. It was signed. So is it just that the technical people or the professionals there that are doing it? So we must do the extent. All that comes to what is called governance.
Yeah.
When you have put the finance together, human resource together, supply together, infrastructure together, how do you govern the governance around it? Yeah. It is at that governance where we want top input and complete commitment to the welfare of the people. The interests must be fought. And I can tell the cabinet secretary, if she means it, she must be ready that not only heads will roll, even lives may roll. I remember we had issues of procurement. Scandals have been in the ministry. We had 2 issues of procurement of drugs and later on, I think, vehicles. And we put our foot down. We got full support. You know, the procurement officers who were involved lost their lives in serious circumstances, which means when we put our foot down, the junior officers who got involved were now exposed. They had to deal with the people they were dealing with out there. The particular example I'm saying, we wanted drugs worth 27 million Kenya shillings, which was going to last us about a year. When it came to the LP, it was 270 million for a drug whose shelf-life is just 3 years. So we were going to either ban or destroy in some way 7 years worth
27 million to
27. Luckily, we found a gap in the procurement. They didn't deliver in time, and we cancelled the thing.
That is 10 times.
Yes. So we cancelled it. And when you are cancelling that thing, the interests are big. But if you have protection from that you can do it.
Yeah.
And also, you must go into that with clean hands.
Okay.
Yes.
Okay.
So, governance.
Yeah.
Then financing. Even the NHIF. Yeah. There's a lot of hand of the ministry in NHIF itself. When these people are being appointed into boards, into boards, we should just look at merit and what they can do. The interests of business people should be competitive.
Yeah. Okay.
So, a human resource.
Yeah.
We must accept, for example, that we are dealing with very special human resource. Being a doctor takes a long time. Being a nurse is very special. And you are a clinical officer, you are an anesthetist. These are people who are well trained. You have to treat them properly. Okay. You have to put systems that manage them properly. We have a problem there as well. So that needs to be sorted out. Okay. Supply.
Yeah.
KEMSA. Let appropriate people be appointed and let them work. There should be no letters from the ministry telling the board what and the CEO what they should do. There should be no phone calls. There should be no SMSs.
Yeah.
Now, if they go wrong, then as action has been taken, then action will be taken. And if we find that there was somebody from the higher level trying to interfere with this, that must be dealt with.
Okay.
So let me tell you this CEO of KEMSA. I told them the first time we met them that, you know, the people who have brought you here are very likely to be the people who will remove you. Yeah. She hasn't taken long. I looked at her, it was called the chair. I told him, you know, now you come breathing fire. When they had these people who had, I don't know, workers, 900, is it 900 workers instead of 340? Yeah. A figure like that. Yes. Yeah. And then there was a court case. 200 workers. Yeah, I saw there was a
now they've all been summoned.
Now they've all been summoned back. What has happened to the court case?
So, yeah. Trevor.
Yeah. Okay. So, and then, then the cost of care, that we can look at.
Okay.
And the ways.
We'll come to the cost of care.
Clear ways of handling cost of care.
Okay. Kigondo, are you convinced with the commitment from the top? You've had Nakumicha herself saying she will uproot the evil spirits. C.S. Kagwe earlier on had said he will dismantle the mafia house cartels. We're still where we are.
So I hope you're listening to Mzee Wakazi here and pointing to who you should appoint in these places. In yesterday's newspaper, it was reported that the President Ruto was infuriated by intelligence reports that the family of a senior member of cabinet was involved in the Bangle tender. Yesterday's newspaper, we are quoting, when I was a medical superintendent in Isiolo District Hospital, and we went to School of Government, there was the concept of accountable officer. The person who puts the signature on either a check, a document, is the one who will be fried, even if it's 10 years later, 20 years later. And that's a very important concept. When you say who is accountable, the person who has signed whatever it is. How KEMSA works, for instance, there are committees. And we proposed, in a memorandum that we wrote earlier, we proposed that Kenya Medical Association be given a slot in the board of KEMSA. I'm pushing this agenda because persons appointed by individuals, as Nyikal has adequately pointed, are held by the individual. Persons appointed by institutions are more likely to do the right thing.
Yeah.
So in the 6 building blocks, as well demonstrated by Dr. Nyikal, one of the most important ones is the health workforce. Yeah? And I want to thank sincerely the President, Dr. Ruto, for actualizing the Kenya Health Human Resources Advisory Committee, HRAC, and appointing the correct people to those positions as per the rules. There is Dr. Joy Mugambi, who was an Assistant Secretary General of Kenya Medical Association. Professor Alice Putungi, who is an active member and a dean at, and the chair, who is well conversant with health systems. That is, but we advise him that the Health Act actually formed this 2017 formed this court, but we need now to give it teeth, because it is advisory and no one listens to advice. So we need to tweak it a bit, and this is the role of parliamentarians, and to make this commission have teeth. It is actually the precursor of what I have always advocated, a health service commission, but we can start somewhere, because the other one seems to elicit emotions. That also to help the counties. The people in the counties have sent me and they have asked that county monies be dispersed to the counties for them to function. You're asking what are the problems? The problems are these. We are here as health workers. We haven't been paid salaries for last month, the month before. Yeah? We have interns who are working in the counties but have not been paid for 4 months. We have others who have not been deployed. So we actually need, and we argued that the way they devolved health was not the right way. Devolution of health is devolve the monies that the counties need to function. And we have had the threats from the governors that they will close down the counties. Yeah. Because that's just a way of bargaining for the monies that they actually should have. Okay. In terms of healthcare financing, government is sponsoring corruption. How is that? The National Health Insurance Fund has not paid health facilities for 6 years. The providers of services go to these health facilities. You go to a facility, they tell you, you go tell NHIF to pay. And unfortunately, for me, Kenya Medical Association is in the board of NHIF. So they told me, you people have not paid health facilities for 3 years. They just closed. So health facilities have closed. Service delivery, access, coverage, quality of safety has gone down the roof. Why? Because NHIF has not paid. And when you don't pay someone, you now start facilitating corruption. You start, now, the health facilities want to survive. They want to call someone in NHIF to say, so you said, you see. So today, if NHIF released the monies they owed to health facilities, these health problems that we have would not be there. So let's have NHIF pay facilities. Many people are dying out there, and if you look in social media, there was one post from a county where Wakili sort of died because there was no oxygen in some facility. Lack of commodities. What is the problem? Again, let's solve the KEMSA issues. And eventually, when we address the 6 pillars, then service delivery, which is the 6th pillar, will go. But most important, leadership and governance. Let us put the right people in the right place. I think if history is anything to go by, if you study the period between 2003 and 2013, just before devolution, you will see that there were the right people at the helm of these institutions. Okay. Let's have good governance.
Davji, are you convinced that there is committed leadership at the helm?
First of all, Trevor, I actually want to, in a way, laud the statement from the CS on that he will exhaust the evil spirits that are there in KEMSA and also do everything that's necessary to make these things functional. I mean, it's a good gesture coming at this time when we know many things are not really functioning. And I will start from the Ministry of Health. I think as we look at these sagas on the sides, we have incompetency that is very well evidenced within the ministry. And I believe these are some of the issues that are probably causing even this delay in the posting of medical interns, even this thing of actually paying of the interns over this period when we know the funds are there. So we should start by also relieving those people that are not actually making things not work in the Ministry of Health. And then that commitment will come by. When you come to this issue of KEMSA, I want to say, also I want to lower down that thing of KEMSA, particularly because as KMPDU, when the government went for, we say, the smaller fish in KEMSA, that is the workers, the doctors that were there and all these other employees, we went to court and got an injunction. The then CS ensured that these healthcare workers remain outside and they continue earning as per the court's order while they're not serving KEMSA over this period. So that in itself, I think, also is a scandal because it's 2 years these people are earning while they're not offering services to that institution. So her returning these workers, these doctors, or these people working at home to work is allowed. Secondly, we have seen situations whereby those who are in KEMSA, who are actually perpetrators of the COVID billionaires, were being rewarded. Yes, they left office as the chair of the boards of KEMSA. Yes, they left office as CEOs, left office at that time, but they got bigger appointments in other ministries. We saw that happening. So if what happened recently is to something to go by, then these persons who are in the process of also pilfering over 4 billion need to put to account. It should not be left that they've just been dismissed and then there's no actions going down to their actions, to what they've done. Number two, Trevor, when there are these scandals we see in KEMSA, it is sad and it bleeds down to the facilities because, as you know, KEMSA is the sole provider or supplier of medicaments and medicines and drugs to all the counties in the country. So when there is corruption of the tunes of 4 billion just for one thing, that is net, it means these corruptions are budgeted. And what do we mean by budgeted? We know Kenya Kwanza or this government was very strong in castigating the incidences of KEMSA. It means that while these people are coming to office, because I'm very sure we all know that the PS was acting from a directive from the top officers. It was very clear in the newspaper, and the names are also very clear. We all know that then this was just coveting and planning the corruption and the scandals while they're appointing these officers. That's why somebody who has been appointed has the guts to change all these documents. He has the guts to know who is becoming the board who will approve these actions. They have the guts to know that the CEO will remain and will execute the same things. So it's in a way, some of the corruptions that were being highly condemned by the government is the same one that the first thing that they're trying to do when they come to office. So this is something that we are saying the president needs to continue with that action and actually bring these people to book. Number two, Trevor, when you look at the healthcare in entirety and the way it is strongly, there's a clear plan. We see it in all these facilities. We have seen a new medsup at Mama Lucy. We have seen a new one in these Korogojo hospitals. We have seen the CEOs of referral facilities. They may not tell you the struggles that they go through, and this they've shared out with me in all these big facilities in the country. Immediately a new chief or a new sheriff has been appointed in those particular facilities. The first thing is the MCS visiting you, telling you what they want to supply. The next thing is the members of parliament telling you what they're ready to give you. The next thing is the different political leaders. So it becomes very difficult when the person who is in office has been, it's actually the directives that they have, that we are going to supply these. So every tender that they're being done by these facilities, there's already somebody that is already being tendered for. So when it's very difficult to say we're going to kill these actions if we cannot make these leaders who have been elected accountable. And for some time, we've been advising these hospital managers that you are not bound to be in that office if you can't stand for it. So that's why they're speaking out. And it is now very important that these leaders know that there is action that needs to be taken from all angles, the parliament, to all these leaders, so that those who have been entrusted with the office actually can work.
Yeah.
On the issue of, particularly I'm going back to the issue of interns, Trevor. We have a shortage of healthcare workers in this country, a serious shortage. And I like the way Dr. Nikal and Dr. Kigondo have brought out the 6 pillars of WHO. These things are known. We have entrenched these things even in the Musimi Task Force report of 2012. We have had policies, some of the best policies of healthcare that have been made by the likes of Nikal, the likes of Amoth, and all the teams from the ministry. And we know the budget, current budget, about 4.4% of it, our national budget, goes to the Ministry of Health. The other smaller budget, about 2% goes to the county. Trevor, the one thing that has been disregarded strongly is the human resource for health.
Yeah.
Which I will not call that, I will call them the health workforce. The one thing that we see is that in the entire country, every Kenyan, when they go to the hospital, they don't demand all these big terminologies. What they demand is they go to the hospital, they see a doctor. You go to the hospital, you get a lab result. You go to the hospital, you get your drugs. You go to the hospital, if you're admitted and you need x-rays and all those radiology, you get the services. That's what every Kenyans need. They don't need all these big terminologies and theories and everything that comes in. But that cannot take place when we have a clear plan where the ministry is focused on policies, the ministry is focused on the donor land programs, and the ministry leaves the most critical aspect of the human resource. Yeah. And this we see when we know the shortage. We need about 50,000 doctors in Kenya to actually have the recommended WHO ratio of 1 to 1,000. Okay. We have doctors graduating every year. Not many, actually. We only have about 900 doctors that Kenya produces every year. That is very little, because otherwise we'll need about 2,000 per year to reach the laboratory recommendation in 25 years. But out of that data graduated, I can tell you they're not being employed.
Okay.
And when they're not employed, it means that there are no services in those particular hospitals. And that is the situation.
Okay.
Number two, we have those interns who are the backbone of service delivery in the counties.
Yeah.
Every county today, when you go, without the interns, the functions of those hospitals are in standoff. There is nothing that's happening. The interns were posted in January. You realize 5 months, they're still fighting. They are in bewilderment of frustrations, begging for their salaries. We have those interns who also need to be posted.
Yeah.
6 months, 1 year, you cannot do anything after graduating, after oathing, because you can't be licensed. It is mandatory to be posted as an intern.
Okay.
But this has not been done. Yeah. Yet we have over 200 billions within the ministries. We have the aspect of training. You know, Triba, and this is the reality, in the next 5 years, Kenya will be probably importing doctors. Why am I saying this? Because the cost of training a doctor, which was 16,000 and has now been increased to 600,000, because I'm sure all of us, when we went to the university, we were paying a fee of 16,000, and that was the tuition fee, and there was help on the side. But that now has been removed to 600,000, regardless of the socioeconomic status that you have. Then they say there'll be some scholarships and bursaries for the needy. And if you can see the scandals that are happening, this is going to be the biggest scandal in the country, the aspect of scholarships.
Okay.
So it means that the Kenyans will not afford these particular trainings.
Okay.
And we will see many, the graduating number of doctors even reducing further, because many will not go to the medical school.
All right.
But those already in school now,
yes,
doing postgraduate studies, who need to be paid for fee by the Ministry of Health, I can tell you, it's a struggle.
Let me bring in Dr. Nyikal. Let me bring in Dr. Nyikal on something that Davji has mentioned here, accountability of elected leaders. And this is not the first time we're dealing with an issue in KEMSA. There was the COVID billionaires. In fact, this is what the Director of Public Prosecutions, Nuruddin Haji, had to say about that probe that the then President Uhuru Kenyatta said should have been done in 21 days. It's been years later, but this is what he had to say in February 2023.
It came back and we were still not satisfied. And you can ask EACC, and they have undertaken to continue the investigations. And if I was malicious, my friend, if I was malicious, a lot of those people come from Upande Azimio. But I'm not going to do that unless there is evidence. And I can assure everybody that if today evidence is brought, packaged in a certain manner, and we discover that this is going to lead to miscarriage of justice, we will withdraw.
Dr. Nyikal, isn't this where the problem begins? Because the DPP himself says that you can go and ask EACC, part one. Part two, he says most of those people are from the Azimio side. In fact, if I was malicious, I would have mentioned them. But also, this is what Davji is saying, that when you're a med soup, you get in there and the first thing that happens is elected leaders come and tell you, this tender is mine, this tender is mine. Isn't that where the problem is, conflict of interest?
See, I told you where it starts.
Yeah.
The top, elected leaders, start with so if we know that at the top, like I said, the minister knows the president will support what she wants to say. The PS knows the minister will support her. The director general knows. All these officers know. The procurement officers know. And they know if you bring a problem, you are in trouble. Now, the elected leaders, part of it is the executive at the level of the president. Then there is parliament, which is legislation and oversight. Now, let's look at oversight. Both the Senate and the National Assembly came on the KEMSA during the COVID issues, made recommendations, indicated where investigation should take place, and get more facts. If the investigation, the investigations are not done, then of course Nuruddin cannot prosecute. That's why it is the whole system. The person, the conductor, is the one who says this thing was passed. Parliament said this. EACC, where is the level of the investigations? So whatever you do, it will really end up with the executive at the top. But they don't have to do it. It has just to be known that that is what the boss wants. And if you don't do it, you are in trouble. And all the henchmen of the boss you know that they're not going to bother you. So you do what is right, and you know you will be protected. That's whether it is in prosecution, whether it is investigation, whether it is execution. You bring an aura in the system, an aura of justice and accountability. Then people toe the line. Now look at, if we go for, say, human resource, we must say there are probably good signs. I'm happy that the minister is actually repeating what the president said. If you remember during the interview, the president said, I'm going to cleanse KEMSA, right? The minister said, I'm going to cleanse. So but the two PSs have been changed. So we are hoping to hear the new PS say, I'm going to cleanse that. And then give the technical people the opportunity. The Director General on side of the technical side, the PS and the procurement officers, the finance officers, the accountants, and all those. So then it will work. In legislation, let's take, he was saying that, he just informed me that KHRAC has been formed. In Health Act 2017, we tried to sort out these issues. And that Kenya Health Professional Advisory Council, we were looking at, and I was actually deeply involved, there's this big desire to have a Health Services Commission. The governors are saying they're not going to have somebody else manage the health workers that is working directly under them. They want to manage them themselves. Then we said, okay, if that is the case, let's have a body that actually to put how you do it. That advisory is, if you want to train a nurse, a clinical officer, a doctor, this is how it is done. If you want to recruit them, this is how it is done. If you want to promote them, this is how it's done. If you want to discipline, this is how it is done. And that is what we did. I remember in the dying days of the 2013 Parliament, going to 2017, we had to even drag the Honorable Machage from Migori and Sipora Kitonyi in Senate to actually finish this thing before it lapses. Yeah. So we put that thing there. If it is implemented, and people must have a sense of responsibility, the governors must agree that if this thing puts standards, and they are members of that, then they will follow that standard. We had this case in the law which provided that if there is a dispute between the counties and workers, not just health workers, but civil servants, health workers included, then the Public Service Commission can come in as arbiter. The last time when there were health workers strike, the nurses and the doctors, they actually reached a point where this was taken to the Public Service Commission, and they actually agreed with the doctor. The governor of Laikipia and Kirinyaga flatly refused to follow what Public Service Commission said. We cannot have institutions and then at some level, people just defy them. Yeah. So even that KHRAC, if it is put in place, then everybody must agree we shall follow the law. You know, the law is, look at marriage. If the marriage only works if the certificate is only useful if at heart you are committed to the marriage and therefore you respect the certificate. But if we have a law and at heart we are not committed to the law becomes a piece of paper. Yeah. Yeah. We must at heart be committed to following the law. Yeah. So if you look at human resource, we put that into place. When you look at supply at legislative level, again in the Health Act, I was there. We said, let's give KEMSA the first call where you will buy drugs. Why? The economy of scale. Yeah. If KEMSA buys large, the drugs should be cheaper. 2, quality. Because they are at that source, they can. And they're not driven by profit, so they can control quality, so that the counties. Now, is KEMSA working? We gave it the first choice. If you gave it the first call, then you have tied the counties to them. Then it must work. But let's look at why KEMSA is not working.
Yeah.
Leave the governance issue. I've said that. People in the ministry must let KEMSA work, and KEMSA must protect it. The president said he'll clean it. Not only clean it, but protect it also.
Okay.
Clean it and protect it. The ministry must also let it work and only come in if they're not doing things right. Leave those phone calls, leave those letters. Yeah. You have a board. The board should do that.
Yeah.
Now, so if the other part of KEMSA, look at KEMSA has as much debt outside as the money it needs. So that if today all the money that is owed to KEMSA is paid, it will be actually financially relatively stable.
Yeah.
But who owes KEMSA? It's the government.
Yeah.
If you look at 90% of the money that is owed to KEMSA, 90% is from the counties.
Yeah.
The counties are saying they can't pay because they don't have the money. Where does the money come from? Treasury.
Yeah.
So in the end, who is in charge of there? It's a treasury level.
Yeah.
No, last week we were saying in our committee, we wanted to get treasury, we wanted to get the Council of Governors, we wanted to get KEMSA, and because if those three are there, then we know who is to pay. The other part of the debt is actually coming from the ministry itself, the Ministry of Health. So if the ministry and the counties pay KEMSA, KEMSA will have money.
But the CS believes that the KEMSA issue is all about systems. In fact, this is what CS Nakumicha had to say in terms of KEMSA. She said that there was no money that was lost, but the issue there that was portrayed was a systems issue. Listen.
Not as yet, except of course the cost of advertising for a tender, the cost of staff having to sit and do an evaluation, you know, just the administrative cost. But in terms of actual value of money lost, not yet, because the tender was now going to be awarded. So maybe at the point of award is when we can speak about loss of funds. However, it taints and portrays weaknesses in our systems.
So now, let me take it there.
Yeah.
2005, 2003, KEMSA was exactly in the same. You know, I was surprised, Trevor, when the new team came, the team that is now going out, and they were giving us a list of, as a committee, they were showing us a presentation PowerPoint on what the problems are. And, you know, I actually told them that I wish I could go back and get the presentations that we made in 2005 on what the problems are. They are identical. So what did we do in 2005? We actually went down. And who actually put pressure there? USAID, same as now. And USAID said they were not going to deal with KEMSA until it was sorted out. Then we agreed, okay, we are going to sort it out. We got a team. We looked at the procurement, who is doing the procurement, for what, and so on. And then we have to put in proper system of proper supply systems. We got people to put in the proper supply system.
Yeah.
And all the donors were very happy. They came back. That is the same time MEDS was just starting. So MEDS was learning from us. So now MEDS goes, and now MEDS is a lot more successful. Now the systems we put there eventually actually deteriorated. And this time, Trevor, when now we were trying to sort it out, do you know they went to the same procurement that I used in 2005? The person called me and said, Nikal, what we sorted out has gone bad. Yeah. I've been called to go back and do it.
Yeah.
Protect it. Yeah. Let the officers, once you have appointed, I think the role of the Ministry of KEMSA should be watching keenly how things are going on, but let them go on. Okay. When they need support, they come in and support it. Like on this debt, they may have to come in and support it. And it has to go to Treasury. Yeah. We need to get money there. Yep. So that system, so legislation, we gave KEMSA the teeth. I was the first, let me not say I, when we were in the government itself, it's the first time KEMSA was allowed to procure. KEMSA was before that a store and a supplier. all the procurement was being done in the ministry.
Yeah.
When the ARVs came in 2005, again we had a problem. And we said, we don't want this procurement in the ministry. The ministry's policy, this agency let it procure. We put all the procurement to there.
Yeah.
It worked for years, but it gradually came back.
Okay.
So that is supply.
Yeah. Yeah.
Human resource, we have told you.
Yeah.
Financing, UHC, Trevor. There is no big magic, that something called UHC. Tell me what UHC is. Let me tell you. Systems are working. The health workers are there. The drugs are there. The services are there. Can people assess them? And if the people assess them, how is it paid?
Yeah.
The government paid through tax, so that makes the system work. Or if they can't, can we have a national an insurance, a social insurance? That is NHIF.
Yeah.
And even this resolution 58.33 of WHA, which came to what is now UHC, actually, the origin is when we made a presentation in Geneva, I think around 2003, 2005,
yeah.
and when the so-called Ngilu Bill was not accented to. And people thought all countries must have systems such as social health insurance, for which will enable every citizen to access health at a cost they can afford. So all the systems are there.
Yeah.
We need commitment at the very level. Let me tell Kenyans that we people in leadership, we must agree to go hungry sometimes so that things are done.
Okay.
Let us make sure that the procurement system, the profits of procurement, the interests do not kill what we are attempting.
All right. So Nyekal can talk forever. You know, but
I've seen.
Let me put it this way, Trevor.
Institutional memory.
Let me put it this way.
Yes.
There is no public or private patient. Yeah. So Mwananchi is saying that when they go to the health facility, there is no doctor. The health facility is far, there are no drugs, they have increased waiting time, and they cannot afford. Yeah? So we need to solve this problem. The correct model of healthcare devolution and delivery was curative health at a national level. You have the medical equipment scheme for equipment and the health service commission for human resources. At the county level, they were supposed to deal with public and promotive health, because once you prevent an illness like cholera, for instance, for every one cholera prevented, you have saved, for every one shilling spent on public health care, 16 shillings is saved on curative health care. So they are supposed to deal with social determinants of health. Housing, if you have good housing, in fact, I'm surprised now, housing should be dealt with at a county level, not national level. Yeah. Water and sewerage, that prevents diseases. Nutrition. So after, then maybe something that we haven't touched on, and maybe you'll need to call another program for that, is that Kenya has never costed healthcare. How much does it cost to serve Mwananchi at the government facility? That's where we start. Private facilities have costed. Talk to Dr. Abdi Mohammed of Ladnan, Gakombe, Team Theory of KHF. They'll show you how to cost, but you will then know how much you need to run the health facilities at each and an attempt was made in 2013. I don't know whether Nyekal remembers that, but this report was sent and it was shelved. It was the end of the report, because it probably said that this money, you need to give it to the county for you to deliver that service code. So we need to cost individual level, family level, and a population level. Then we can channel the money to what we are going to now, primary healthcare, PHC. And we need to shift now our focus to physician-led primary healthcare, PHC. This, you have a hub and spoke model, and at the base you have community health workers. They have changed the name a bit to promoters. I might need to know what that is. So when you have that base, you have PHC at the community level, and then you have the hub and spoke, which is a physician-led, and then you have all these feeding into that. And when you promote PHC, then UHC is achieved. You prevent diseases, but you have also strengthened the curative model. So but let's cost healthcare.
This physician-led issue that you're talking about, the PHC, we also have to talk about some unethical conduct of the same physicians we're talking about. And this is an accusation that has always come up. that sometimes you then refer people to other places, there's misdiagnosis here and there. How then can that be addressed?
So again, you've mixed, like the press normally do, many issues. So if you are dealing with an unethical practice, deal with it that. Normally what happens is people throw the baby with the bath water. So you say, if for instance, we say a cabinet secretary was involved in some corruption, then we make a statement like all cabinet secretaries are corrupt. You see, so that blurs the picture. So let's deal with individuals as individuals. If someone, and again, part of the problem with health is that the autonomy has been taken away from the people who are supposed to be running healthcare. And this was an argument I had with one of the governors, who, when I told him, by the way, a health service commission will help devolution. He told me, if I can't control my workers, then I do not have power over them. So what happens? The health workers, of course, they cannot control. But if you allow them to do like we had in 2007 to 2013, where each individual unit is accountable, it becomes easier. So let's not throw the baby with bathwater by throwing in, that confuses things. A physician-led primary healthcare model. You see, there has been this concept that, oh, no, doctors cannot work in the community. No. In fact, they're the right people to work in the community. They've been seeing, like, I'm an obstetrician gynecologist. I ran a clinic yesterday at a county hospital. And the problems I am seeing, I have already identified the problem at community level. So I should be the one to generate policies and also guide. I should now also be going to the community to say, you cannot be having cancer of the cervix at this stage. Why? They went to the community. No one has ever gone to tell them you need screening and all. You see, so that concept of health needs, you don't dichotomize everything. It's neither here. It's just the way they are trying to say there is curative health and preventive health. No, it's a continuum. One feeds into the other and the other feeds, which was the same thing like what they said in Schedule 4, referral health facility. Referral health facilities were from dispensary till level 5. There was referring and reverse referral. So when you now start saying referral health facilities is Kejata, Mathare, you have killed the previous concept, which was in National Health Sector Strategic Plan 2 of 2007 to 2010, so for your benefit, so that you say, oh, health is devolved. It's not devolved. It's a shared function with misinterpretation.
Okay, Davji.
Yes. I agree.
A shared function with misinterpretation.
Yes,
Davji.
I really agree with the sentiments brought forth by Kigonji, particularly on this aspect of physician-led community engagement or the primary health care. Because you see what, and this has really been mind-boggling, when they say we are going to have 100,000 community health promoters. Yes, it's a good thing. But now, when you have them in the society, they have identified people who are sick because they cannot actually diagnose the particular conditions that these people are having. They've enlightened them. They've told them to go to those facilities or to different hospitals early enough. But they'll be going to shells. They'll be going to in facilities where there's no doctor, there's nothing to be done there. So in essence, their effort will not be any fruitful. And that's why there's actual need to have doctors and other health workforce be part of this process, because then that is what actually we call Alma Ata, that declaration of 1978. Not just one side, you say this curative and this promotive. But I can tell you, Trevor, we're in a striking nation, a nation that MCAs are going on strike, a nation that the governors are yet to go on strike, I think, in the coming days, a nation whereby as doctors, we've been issuing notices, and I'm very sure before the end of this year, if things don't change, we'll also be forced to go on strike. It won't be strike for us. We'll be going on strike together with the society, because for the first time, I've seen Kenyans really relating with the issues that we've been speaking about, because they go to the hospitals and they get frustrated. Trevor, healthcare can never be free. If somebody has to pay, it's either the government fund it in the right way, or it's either the public goes to the hospitals, sell their lands, sell their properties, and get access to the healthcare. So that is a reality that has to be seen for us to have a functional healthcare. But that can only happen when we make this document, this institution like HRAC. I don't object to KEMSA, really. But then the functionality and the enforcement, as Nikala had brought forth, we have many bodies, we have many policies that are there from the Ministry of Health, but how is the implementation? As a union, yes, we will be advocating for the amendment so that also the workers, or the healthcare workers, can be part and parcel of the process of these of the membership of the KEMSA. But now, what will be the enforcement of the policies? Because the issues that are bedeviling healthcare in the counties, for example, delay salaries for the healthcare workers, how will that be sorted out? Because we know it is in law that people should be paid by 5th. We know the issues of promotions. We call the manuals on this. We have CBAs. We have seen counties not implementing these documents. So I think KEMSA should not be another institution that will just be used with taxpayers' money without anything that is being implemented. Okay. So ideally, I support what Nikala says. We need to give KEMSA a teeth to ensure there's implementation framework of this, of the recommendation. All right. Because Public Service Commission, when they make a recommendation and the governor fails to comply, then we can actually compel them with the court. Yeah. But what about the KEMSA that we are putting into place? So there are things we need to look at. Okay. The last thing I want to say is the defunding of NHIF. We know, Trevor, that we say that I'm hearing about, we talk about the costing of healthcare, investing in healthcare, but the government is deliberately defunding the most regarded and the most expected social service provision in through NHIF. Why am I saying this? As at now, the parliamentarians, the state officers, the county, they've all run away from contributing to NHIF. They've all gone to private insurance, which as I saw yesterday, up to 130 billion of taxpayers' money go to private insurance. It then means that all this money will go to big boys institutions or big boy private facilities. None of it will actually serve the Kenyans. So in that process, NHIF is defunded. We have NHIF hold about 30 billion by the Treasury. So even those private hospitals that need to offer care in the situations where the government and the county governors have refused to actually invest in healthcare cannot survive. Okay. So we have to look at that. And you see on this side, we have 2.75% increase deduction from the workers, which we have objected because it is a crime on the workers. It will be a criminal offense to tell me to pay 100,000 or 150,000 per year for insurance or to NHIF, and I cannot get any care in any facility using that card. All right. Let me bring up some feedback really quick, then I'll take closing remarks. We're really running out of time here. Let's see, there's a lot of feedback coming through. Let's read a bit of that, and then I'll give you each a minute for closing remarks on where do we go from here. Let's bring that up on screen at Trevor Mbija at Citizen TV Kenya. Use the hashtag Daybreak. Let's read that, a few of them. Honorable Lillian CEO, he says, Kenyans must stop politicizing the war on corruption. Whether you support the government or as Azimio, never defend corrupt leaders, okay? Remy Butia says, in Kenya, food safety issues are often overlooked until a major scandal or a tragedy takes place. Our response to food safety is often reactive than preventive. Government should consolidate food safety functions into one independent agency. Okay? Okelo Mwalimu says, to institutionalize perpetual public theft at KEMSA, the outfit should be renamed Kenya Medical Scandals Authority. An institution that becomes a cash cow should either be disbanded or rebranded. Is it time to replace it under military control? Maybe yes. Okay. Samuel Wood says, our health sector must be very lucrative. We've always seen every financial year the health sector being one of the sectors highly prioritized in terms of funding, yet it's the most mismanaged and all hospitals mistreating patients, etc. Bob Otieno Wino says, the only remedy of restoring better health care to Kenyans is by reverting health docket to national government because county governments have failed miserably. Okay? Ole Shonko says it is sad that an individual can put the lives of people on the line to enrich themselves at whatever cost. Life no longer matters to some people. Our values have eroded and any appointment means enriching yourself and not serving the people. Sir Nixon says, now that it seems like poisonous sugar is already in the public domain and most probably already consumed, besides sucking government officials, shouldn't the consumer be taken care of? For instance, be offered free medical tests. Reverend Harry Kosgei says it's time now every ministry to do every past mess done by
their predecessors in their various parastatals. Let heads roll, people taken to courts, and what the president said very quickly is good and should not stop, e.g. COVID billionaires and other scandals as well. Bob Otieno says devolving of health docket to counties created a lot of loopholes, which has led to massive corruption deals contributing to poor health services, as we are witnessing at KEMSA. To end this menace is to revert it to the national government. Godi Baraza says Dr. Susan Nakumicha should be supported and protected to the maximum. Her resolve to clean up the mess in the health sector is the much-needed initiative she has undertaken. Cartels and rogue servants must be strongly and fiercely dealt with. Dr. Nyikal, closing remarks on this. Where do we go from here?
Well,
yes, and
where we go, we have told you we have actually we have mentioned the pillars of health sector, and we have put governance at the top.
Yeah.
Then with proper governance, financing, and then let the professionals take the lead.
Yeah.
You mentioned something that what about the health workers themselves? There have been questions of misconduct and so on. That is true. Even in NHIF, we are concerned about collusion of providers, but those should be taken care of, as Dr. Kigondu said. Those will always be there. But my summary is governance, finance it, and give autonomy to the institutions and protect them when necessary. Those two are not contradictory. You can give autonomy but also protect. That is what. And let health be given the priority it serves. Human resource and supply are now the biggest failing in the health sector. Now, primary health care promotion is good because it will reduce the cost. We must look at that. We didn't discuss it today, but we must look at health promotion, prevention, and primary health care to reduce the cost at the higher level, which should then be dealt with in the way we have said, management, health financing, and protection of the system.
Okay, good. Closing remarks.
Thank you very much. I think to help CS Nakumicha, there's a policy brief released on April 24, 2018 called Sealing Corruption Loopholes in Kenya's Health Procurement Systems. This was done by Transparency International and KELIN. TIKMA is a member of KIA, and coincidentally, this report was launched on World Malaria Day on 25th April 2016. We are talking of the nets. We want the Human Resources Advisory Committee to be given teeth. We want NHIF to pay all pending dues for all the facilities they have, and we want funds released to the counties so that our salaries can be paid and counties can function.
Okay.
Thank you very much.
All right. Davji, closing remarks?
I'm just saying that I think governors must now be honest about the dysfunctionality of the public health care in the counties, and particularly because they can see that they can't employ, they can't offer services as necessary. So it's a time to actually put themselves as service seekers, those who really want to get the care themselves, and actually have a turnaround aspect on it. Lastly, I want to say, as we focus on the corruptions in these bigger institutions like KEMSA and the likes, we should not forget down into the counties where we have even the county public service boards, who, whenever they advertise any positions, they look at it as a money minting mechanisms for the doctors and for the healthcare workers. And so for us to fight these corruptions, it must start from the root, and also it must go to the top.
Okay.
So all aspects.
All right.
Finally, I want to say that finally the ministry must commit to sort the issues of interns once and for all. It's not really proper that every year we come for the same thing.
All right.
Thank you.
Thank you very much for making time this morning, gentlemen. Honorable James Nyikal, Member of Parliament for Seme, and also a long-term serving Committee for Health member, and also a doctor. Vast knowledge on this. Thank you for making time. Dr. Davji Atela, KMPDU Secretary General, and Dr. Simon Kigondu, KMA President. Thank you so much for making time for this discussion, and thank you all for all the feedback that you've sent through. Coming up now is Level Up Friday with Willis Bazura, Buru, it's DJ Carbon on the decks. All right, see you in just a bit.